here today to talk about my favorite topic. And it is my favorite topic about caregivers' mental health because this is what I've been doing my whole career. And maybe it's the other way around. I've been doing this because it's really something that I've seen that is really important. I started as a social worker in the memory clinic at Baycrest, and I saw firsthand, this was in the early 90s, the struggle of caregivers. And people would come to the memory clinic with, please give me a diagnosis, only to find out that really the most important interventions were the psychosocial interventions. And so I learned very quickly that the importance of supporting and working with families then. And then I've been at Baycrest for over 33 years, doing different things related to caregiving. And then I was very fortunate to go back to do my doctorate and really specialize in dementia caregiving to learn more about best practices. And my interest is more the younger onset dementia population. However, a lot of it applies to late onset. So today I'm going to talk about not necessarily about the young onset, because I think most of you probably work with late onset, but please feel free to ask questions related to this topic and to ask me to condense in 20 minutes the important things about mental health and caregivers is really hard for me. So I'm going to do my best, and what I don't get through this presentation, which I won't get through a lot of this stuff, hopefully I can incorporate during the discussion. I have no disclosures, and I really will see how much we get through. I just want to give you a bit of context about understanding the needs of caregivers and to identify which ones are the caregivers that need help and what kinds of supports are needed. And I just want to talk a little bit quickly about language. In terms of caregivers, there's a lot of people call care partners, carer, caregiver. At the end of the day, it doesn't matter as long as people understand what you're talking about. And it's not that language is not important, but I was told very quickly, just stick to using the word caregiver, because when you start using care partner or carers, the only people that understand you are the people in the field and nobody else. And that's why I use it. I was a few weeks ago at the Canadian Caregiving Conference, and interestingly, there's new terminology, so I'm just sharing it with you so that you're aware of it. Somebody talked about this idea of care gifting, and he was Cree. He was a PhD, and he talked about culturally for him, everything's about relationships, and in the context of relationships being of great importance, if we think of caregiving as a gift from us and not expecting anything in return, it makes it as part of that natural caregiving situation. And that was another word that was thrown around. Because family caregiving, a lot of people are not happy with that term because it excludes potentially friends, families of choice. People do not like the term informal caregiving because there's nothing informal about what they do. And they don't like unpaid either, because in an ideal world in Canada, family caregivers should be getting paid for the work that they do. So I'm just throwing those things. Loved one is my other one. In healthcare, we always a lot of us talk about family members as being their loved ones. Your loved one went into long-term care, your loved one. And that's presumptuous of us to assume that just because somebody's related to somebody that there's love there. And so sometimes it puts caregivers in a situation that they can't share with you how things are going for them, because there may be a long-term problems in their relationships, and the person's not a loved one. Maybe it's a partner who they're about to divorce and they get a diagnosis and now they feel stuck. So just to be mindful, better language sometimes are things like your partner, your spouse, your mother, and there's no judgment there. And just in terms of older adults, just so that you're aware, family caregivers provide 80% of all the care to adults in the community and 30% in institutions. And so these are not minor numbers. you can have these stats and look at the numbers later. I won't bore you with that, but André Picard was talking about family caregivers, and I really liked it when he said caregiving should be manageable, not backbreaking. And a lot of the families that we see, it feels like caregiving is backbreaking for them. I also there's a lot of difficulties around terminology, and especially in the literature. Caregiver stress refers more to the psychological and emotional responses, and caregiver burden is more all encompassing. It's like financial, social challenges, physical, and everything else. In terms of the effects that we know, and just so that you know, and I'm not going to get into it here, but the methodology in caregiving and in dementia caregiving is really flawed in many ways. The studies are not high quality, understandably. So a lot of the things that I'm going to say, overall, it makes sense. But if there's 4 million caregivers in Ontario, 8 million caregivers in Canada, there's 8 million different experiences, because a lot of it depends. However, caregiver burnout is pretty common, and you could see it through people get frustrated easily, or a lot of older adults express depression, feeling overwhelmed, and they'll talk about being tired or having aches and pains, not doing things that they used to enjoy, being forgetful, foggy, easy to anger, anxious, depressed, and helpless and hopeless. In men, there's more research that women tend to have more anxiety and depression, and men have more metabolic illness. There's a lot of social isolation, and this became so clear during and throughout COVID. I mean, it was social isolation for a lot of older adults, but those that were caregivers were particularly at risk. There's also a huge financial component that we don't necessarily talk about it, and yet for caregivers, 94% of Canadian caregivers say that that's their biggest stressor. And it's something that most of us can do very little. In Canada, we do not have good compensation, and even tax credits are for only a particular group of people, and only 8% of Canadians that would qualify for these tax credits avail themselves of them. So that may be something that you could suggest if it's applicable, but it's very problematic. There's also a lot of strain in families that occurs as a result. I mean, there were problems before, and the dementia diagnosis and the context of it exacerbates a lot of the problems. And as many of you know, dementia caregivers, and this is not just spouses, are at 600% increased risk of developing dementia themselves. I mean, that's huge. And some things that shape caregiving, because when I said it depends on the context, is the intensity of the level provided. It's very different whether you're giving 1 hour of care or 24 hours of care. There's also something that there's a difference between the actual caregiving duties and the worry and anxiety around caregiving. And that piece of worrying about caregiving plays also a huge part. And a lot of the times it's not measured. We ask people how many hours of caregiving, how long have you been caregiving for, what's the relationship like? But you could have, as I call, the son from California. I mean, I always refer to the daughter from Toronto and the son from California, the daughter in Toronto doing all these tasks, and the son from California calling and telling the daughter, do this for mom, she needs to do that. Why didn't you do this? And we can't underestimate the son from California's level of worry and how that impacts his life and his family's life as well. But it impacts it differently than the local daughter who's busy doing all this stuff. Also, the timing of entry, if you become a caregiver to a partner in your 40s is different than in your mid-80s. Diversity, I mean, that is a whole thing unto itself, how different cultures and caregiving expectations differ so much. I have a student from India, and she tells me it's the oldest son, and because he's so busy working, it's her brother. It's the oldest son's wife who does it all, whether she likes it or not. Even though this daughter is willing to do it, it's not for her to do it. So you can only magnify that to all the different combinations of cultures that we have in Canada. And never mind cultures, gender issues, socioeconomic status, etc. The other thing for you to be aware of, caregivers that feel forced to become a caregiver fare worse, and women fare worse overall. But could it be that because for women it's less of a choice to be a caregiver, they're more likely to be the primary caregivers, and there's greater societal pressure to do it. And even I can only speak for Ontario, but in our home care system, men that are caregivers tend to get more hours of care for their for their wives than the other way around. Is this a bias? Yes, it is. So I've been asked a lot of the times, what's the best instrument, scale, tool that you could give us or tell us to support family caregivers, to identify who those caregivers are? And there's a few, but I really am here to tell you that you don't need to be, unless you're doing research and numbers are really important to you, you're just creating more work for yourselves and for the families that you serve. There's nothing wrong with asking a scaling question or asking someone, how are you doing? It's really hard to be the partner of somebody with dementia. How are you? The problem is that when you ask, you have to be prepared to listen and do something about it. So if you have no time, if you don't want to know really because you can't deal with it, then don't ask. Or say, I imagine it may be hard for you. Would you like to speak to the social worker on the team or whoever that may be? If you're going to give a scale, I think the Kingston one is probably the better, most succinct one. Having said that, I don't know how you use it in a way that's better, more effective than just asking people how they're doing, really. Other things to keep in mind is that we all know this, dementia is for a lot of people really long trajectory, and different things, different strategies are helpful at different times of the illness. So at a point of diagnosis, sometimes you can't even overwhelm people with education because they're not even there. They're not even understanding what the A word means, and they won't even call it Alzheimer's. So you need to understand where families are at. And the other thing I want you to understand is that placement to an institution, people that are further along, does not alleviate caregiver stress necessarily. Because now families, a lot of them, even though they are relieved that they don't have to provide the 24-hour care, now you have to trust an institution to look after your relative. And in a post-COVID world, this has become very difficult. Knowing, what if I place my relative and they die? What if I can't visit? There's been a big rupture of trust with governments and institutions. And will somebody tell me when, I should stop talking? Sorry. Megan, will you just...
You can definitely take more time, Adriana. We don't stick just to 20 minutes.
Okay, just tell me that's enough because I can keep talking. So there's generally two kinds of strategies when we're dealing with caregivers. One is around improving their coping skills and emotional well-being, and things like support groups, counseling, educational interventions are appropriate. And the other one is around reducing the amount of care, giving people respite, hands-on support, PSWs. And I know in different parts of the country, we don't call PSWs, but people that provide hands-on care, basically, assistive technology for people. So there's those two. And interventions that are helpful are when we combine as many multimodal interventions for people. The other piece that I don't want you to forget, because it came up in another discussion, is consulting with the person with dementia's physician around medication strategies. All I can think about is a caregiver who was sleep deprived because the partner was up all night, and something that perhaps a medication could have made a difference is worth exploring. So it's not always for the caregiver, or try some mindfulness interventions support for yourself, for you. Look at it as a dyad, and the interventions are not necessarily for one or the other. In terms of the kinds of supports, what people have said, so 90% of Canadians have said that having someone to call or a point of contact person is one of the more important things for them. And so when we're designing services, and I know I'm just going to speak for Ontario, our services used to be long-term case management approaches, people could call, and now more and more they're like, you've got 6 weeks, you've got short-term kind of intervention for now, call me in the future. But if people can have a point of contact person, that is very, very helpful for them. And the other piece is, when appropriate and when you're able to have other resources, to discuss with your team what other things people could provide. Education is very important, but a lot of caregivers will tell you they don't want yet one more module because they're not sitting in front of the computer. And so being aware of the different learning styles of people need to learn. It's really important. And caregivers will say they need to understand the progression of the illness and the implications. But we also need to be very creative on how we share that information with caregivers and families in a way that is appropriate to what they're going through at that particular time. And sometimes we're very quick to refer people to support groups in the early days, and people are not ready. A lot of the times, people will say, I don't want to go to that support group. I don't want to know what's ahead for me. It's depressing. And we need to listen to people when they say those things to us. And perhaps at those moments, more one-on-one interventions are better. I'm not going to... The other thing is just some general strategies. So if you're not a social worker, you're not a counselor, you're a physician, you have 3 minutes with the caregiver, what can you do that's helpful? First thing you could do is identify for the family that they're in a caregiving role. Research shows that those family members that understand that they're in a caregiving role, they do a lot better, because it's easier for them to ask for help. They realize that this is above and beyond being a partner, a daughter. So if nothing else, just say to the family, do you realize that now that your partner has been diagnosed with a dementia, that you're in effect a caregiver? You're also a partner, but you're also a caregiver. The second thing you could do is just validate what they're going through. When they tell you, this is really difficult, don't say, oh, here's a phone number for the Alzheimer's Society. Because what you're doing is you're trying to help people by, here's how I'm helping you. Here's a phone number of somebody that could help you. But you could do that after saying, when somebody says, I'm going through a really hard time, even a small sentence paraphrasing what people just told you. Like, I can't imagine what it would be like to be the partner of somebody with dementia. Are you interested in having a phone number of an organization, wherever you live, that may be for you. Don't just be quick to hand numbers and solve the problem. Just listen to people if you're able to spend the time. I'm not going to ask you to identify what kind of stress they're going through, because depending on what profession you have, it may not be so obvious. But if nothing else, there's refer Alzheimer's Society, but the other people that are really good are 5 of the provinces have a caregiving organizations. They have a phone line 24/7. BC, Alberta, Ontario, Quebec, and Nova Scotia. They're very helpful for people. I mean, chances are that they're going to end up referring them to their local Alzheimer's Society chapter, but they also have a lot of support groups and educational materials. They're fairly new, and the Ontario one's fairly new, and most of them, but they're doing great work. So check out their resources as well. So I don't know if to start the next section. Maybe I'll stop about strategies to engage and support family caregivers. But maybe we can talk about it, and if there's time, and you have the slides, you can use them, or I'll leave it up to you.
That's great, Adriana. Thank you. We actually may have time to come back to this because our case presentation is not going to go as expected. So we have more time to play with. Before we talk about that, we have some time for questions. What do you want to ask Adriana? While you're thinking, I want to thank you again, Adriana. That's such a great presentation. And I learn something new every time I hear it. So thank you for doing that for us.
My pleasure.
Go ahead, Claire.
Hi, Adriana. Thanks very much for that. That was really interesting. You made a comment about caregivers being at a much higher increased risk of developing dementia themselves. And I'm a bit curious if we know anything about why. Yeah.
So there's not one straight answer of why. It's multifactorial. And there could be environmental that we don't know yet. There's the stress and worrying and the lack of self-care. And we know the dementia risk, like poor sleep, poor eating, not exercise. Megan, help me with other of the risk factors. I'm thinking of the defied dementia.
I know, so am I.
And all these
things like depression and stuff like that.
So there's those things, and they worry. But truthfully, I don't think the jury's out around. Are there any environmental factors people that live in the same household experience that could or could not perhaps have an impact? But what's really helpful about that statistic is that it helps family caregivers when you're trying to help them understand the importance of self-care. Is that there's some people are petrified. Adult children is the first thing, oh my God, I'm going to end up like my mother. And spouses worrying, if something happens to me, what's going to happen to my partner? So it's a good number to give people to say, but there are things you could do. 40% of the dementias are potentially preventable. So that generally engages people.
Super.
Is that helpful? And there's quite a few studies. Norton in 2010, that group started with it around spouses. And since then, Vitaliano, there's a whole group if you search the literature.
My other comment was just going to be around what you mentioned about having caregivers have somebody, a nurse or somebody to talk to. And that it's my experience with 2 parents who have had cancer that is the case in the cancer field. And that probably we have some things to learn from in other fields about how to do things a little bit better. But thank you very much for that.
Thanks.
Kathy, I'm going to go to your hand next. I just want to give some context. So Adriana and I said Defy Dementia. We're working on a podcast and a series of educational resources at Baycrest, and it's called Defy Dementia, and it's all about the modifiable risk factors associated with developing dementia. So I'll put the website in the chat, but the podcast is available on all your podcast platforms. We also have short videos and animated infographics that you can share within your practice. It's all open source content. So feel free to copy and share and send it around if it's of use to you. Kathy, go ahead.
Are you putting that into the chat so we can highlight?
I will, yes.
Excellent, thank you. I'm curious, I'm new with dealing with geriatrics. Usually my population was always around the age of 40 for the average age of my clients. I'm a nurse practitioner. Currently, my average age of clients is 70. The only reason it's 70 is because I've got a newborn in my practice.
Oh, wow.
Wow. Anyway, of course, I deal a lot with clients who you see them declining and the caregivers are like, you see them tiring out and wearing down, but they're adamant that they're managing. How do you gently discuss with them that it's time that you look at doing something more before you burn out and something serious happens to your partner?
It's an interesting question because I can tell you the answer, what we should be doing in reality. And if you've been a caregiver personally, you understand it's not so easy. And there's times in our lives that we're more able and willing to accept help than other times in our lives. And some people, caregivers, cope by just keeping busy. I know I'm fine. And they feel it's an expectation. And they also feel not only it's an expectation on their duty, but at the end of the day, we say, look after yourselves, but there's nobody to look after the person they're looking after. And if it's somebody that needs constant care, it becomes really difficult. And depending where you live, there's very few respite services. Home care services are really expensive. Placement is very expensive. So I think just being kind with people and just, if you have the luxury, it shouldn't be a luxury, but in our healthcare system, it is a luxury of having time with people where you can really listen and not necessarily initially push for answers. Do this, you should be doing that. Just listening to people and building that relationship will go a long way. Also, what we see from the outside, different caregivers have some people are very resilient and can do a lot and put up with a lot and be okay. And some, the smallest thing stresses them. So in an ideal world, if you can build a bit of a relationship with the person where they trust you and when it's appropriate, then you can suggest. It looks like it may be helpful. And the more I do this work, the more I realize that I have to tread lightly and be gentle instead of being so prescriptive with people. And you have to know your audience, your clients, but you're more likely to engage them. And sometimes, I had a client, somebody I saw a few years ago that I saw like 20 years prior. And she said to me, the first time I met with you, I was so angry because you told me what was ahead and I didn't believe you. And years later, I came to realize why you were telling me what you were telling me. She kind of said it a bit as a compliment, but I took it as a negative. For me, thinking, it's important to know when to say what kind of information sometimes. And are people ready or not? And I'm not being tough on myself, but what I'm saying is, listen, if you have the luxury of time, listening to people's stories and where they're at is a good first step before we start pushing with our interventions for people. Is that helpful?
Thank you.
Thanks, Adriana. There's a question from Lauren in the chat. I'm going to read it out. It says, do you have a favorite resource for teaching caregivers about strategies to communicate with those living with dementia?
Yeah, you can check the Baycrest website. There's some there. There's also, is this to teach? McMaster has some really good resources. Also, McGill has some really good resources. Do I have a favorite? No, I think it depends. My favorite really is for healthcare providers to know these strategies, and to be quite honest, is to practice them or do it with the families if you have that luxury of time. Because paraphrasing short, we know, or some of us that have been doing this for a long time know what those strategies are, but you have to know your audience too. And there's very different levels of ability in caregivers, languages that they speak. So being a bit strategic. I don't think it's that easy, but Baycrest, McMaster, and McGill, their websites have good information. And maybe, I don't know if somebody is here from the Alzheimer's Society and there's resources there, please speak up. The other one, there's, sorry, yes,
go ahead,
okay.
Go ahead, Adriana. It was just me.
Sorry. The other one I was checking lately, I don't know if you're familiar with Trualta. They do a lot of education. It's a business to business model. They have all kinds of online modules and educational materials. Some of it is good. And they're hired by some of the insurance companies to provide services for their employees. So if people have access to that service, some of it is good, some of it not so good. So what I suggest is check out the resources, and maybe if you can compile a few from the different areas that you feel are good and helpful.
And if people, within the group, if people have resources that they use, feel free to put them in the chat, and we can kind of work off of the hive mind here. Marie-Lise, I see your comment. Can you, if you're able, can you unmute and speak to this? What do you mean by pro-attention plan with families?
I think I come from a long-term care background, and I think we very often apply a pro-attention plan to the residents where we work to, put things ahead of the game so that we're constantly checking in with the residents and making sure they're okay and things like that. And I think sometimes we don't do that with the families, especially ones that we see that are struggling a little bit. So I find sometimes when you take that ones, especially I find some of the families that are a little bit more of the squeaky wheel, so to say. If you can take that time and you're checking in with them a bit more routinely. So there was a few families that I actually set up weekly phone dates. And I was like, okay, so how are things going? What's going on? What can we be doing better? What's the issues? And honestly, after a few weeks, you were starting to talk less about what their concerns with the home were. And you were starting to just hear, I had one lady starting to tell me about the divorce she was going through, and she was going through breast cancer. And there was this whole social background happening in her life at the moment. And not that it made it right by any means, but unfortunately we were getting some of the brunt of it because she was caring for her dad, and that was the way she could kind of control something. And so, just if you're able to kind of do that and build that relationship and build that trust, and that I was always able to go back the next week and say, okay, these were some of the concerns you had, this is what we did to correct it. So building up that trust and getting some of that understanding and almost having that pro-attention plan in place was helpful with quite a few of the families.
Mary Lise, you call your same Mary Lise together?
Yes.
Yeah. I'm from Argentina, and what never ceases to amaze me in North America, this idea that our patient and our client is the person with dementia. The family, they're not our clients. And we can help them around caregiver stress related to their parent, but we cannot help them with the stress related to the cancer or divorce or whatever else. And I say I'm from Argentina because it's more of a collectivist kind of holistic approach. I would never think of, oh, that daughter. And I'm telling you, it's happened to me where I've said a social worker would be helpful if she helps the daughter. And it's like, no, because it's not related. We don't get paid to support families unrelated to issues related to caregiving. I just don't know where you begin to differentiate what's a caregiving stressor versus when somebody is stressed because of other reasons or depressed. And like you said, building that relationship is so important and listening, because sometimes, even if we think of it from saving time perspective, if we can listen to somebody and understand where they're at, it'll save us a lot of time for people that just we perceive they're complainers or they're always, after us. Sometimes they just need support, and we're all people, and this is the other idea that we're all humans, right? And if we put ourselves in the shoes of these families, how horrible. And it's good, but you are out of control. And for some families where they feel, at Bakers we have Holocaust survivors, adult children tend to be very protective of their parents, and so being mindful of those dynamics for people, being mindful of their understanding of health. And in terms of culture, what does it mean for some families in certain cultures to place their parent or their relative? Are they failures? And so maybe they're constantly calling you. It's just a way for them to feel engaged and less guilty, right? So trying to understand some of these dynamics and really being easy with, understanding that, hey, they're in a really hard spot. We're in a hard spot because healthcare is so stressful, but they're also in a really difficult position for various reasons. So, it's great that you did what you did, that you were, and it's great that you identified that, and it's great that you made the time to do that. And I think it's in the end a time saver for people.
Yeah, I think you're probably right. Kathleen says sometimes the biggest impact we can make is supporting caregivers.
Mm-hmm.
Okay, Kaylee, you have a question about hospitality. Go.
Hi, thanks. Yeah, a few years ago, I read this book by, I think her name is Victoria Sweetland, God's Hotel. And in it, she talks about like hospital, and the root word comes from hospitality, and how it's like a two-way street. And so I know, like for myself, I think it's the most rewarding part of my job is working with these families, and they're calling you and you get it, right? And so I just wanted to make that comment that, talking to these families as their parents are going through these extraordinarily difficult situations, it's like it feeds us too, and I don't know if you guys have experienced that, but it's the most rewarding part of my job, and I sometimes bring that up with families about that, that hospitality and how it's this two-way street. And I don't know, I just wanted to say that.
So thank you. So were you saying that it's a two-way street because us as healthcare providers, we get benefit from doing the work that we do? And I suppose many of us chose these professions for a reason. It wasn't random, right? And a lot of it, for me, I can say that it's been such growth experience personally doing the work that I do, right? But it's the other piece of working with dementia, well, any kind of people, but it's being aware. It's just awareness, self-awareness is so important. Like what belongs to us, what belongs to the families. I'm being very mindful of who has an issue, right? Because sometimes we find issues that are our own issues and not necessarily the families, right? So that work, that personal work around awareness when we're working with our families is so important.
I think, Adriana, that's a really important thing to remember, you know, what we bring to the table and what they bring to the table. But Kaylee, I want to acknowledge that was a really beautiful sentiment. So thank you for sharing that. David, go ahead.
Yeah, thanks so much, Adriana, for this great presentation and discussion. You mentioned grief after the person with dementia passes away. And two questions about that. One is, what about grief along the journey? Because you often lose that person, you know, step by step, aspects of the person anyway, and whether you sort of conceptualize that as grieving along the journey. And then the second question is about our system to help people who are grieving. It's so hard to find resources, and you know, if the person dies in long-term care, the social worker in long-term care is finished generally with them because they're busy with all the new people coming in. And just if you have any thoughts about how our system's kind of not integrated enough from that perspective. So it's kind of two questions.
Thank you. And so I'll answer the second piece first. I'll talk about grief post-death first. It's interesting, in California, they allow 18 weeks post-death of any patient to continue to provide supports to the family around grief. And this is the US. In Canada, we don't, or in Ontario, we for sure don't. The person dies, you're instructed to close the case. And if people continue, is really kind of just a quick phone call, but they're not really allowed to continue. There's a really great resource out of McGill University. Pam Orzak is her name. She's a prof at McGill, the School of Social Work. And I'll give Megan the website. It is a fantastic website with resources for families that are grieving to continue their work. It's fantastic. It's really great resource. So I'll pass that along. And it's something that we really should be strong advocates in healthcare, that supporting families is part of healthcare. And you know, there's two schools of thoughts where people feel, no, well, they're not, you shouldn't pathologize family caregivers, they need care and support. I don't think it's pathology. I just think it's really part of the human experience of being a caregiver. And if it's not the healthcare system, who's going to do it? And so I think it's important for all of us to talk about that. In terms of the grieving process, especially with somebody with dementia along the way, I'm not sure, but you may be aware of the term ambiguous loss. I think it's Paula Boston. Is that her name, her last name? I can get you also the resource after the fact, who's done a lot of work around this idea of the grief for caregivers, in particular dementia caregivers, around losing the person throughout the process. And yet you can't grieve the way we normally think of grieving, because physically the person's there. And yet we're losing not just the person, but the relationship we had with that person. The grief also around that a lot of things that you thought you would do with the person as you were older, you became older. You know, we're going to retire, we're going to travel, we're going to do all these things. And, you know, and dementia is, for a lot of people, it's like over 20 years trajectory. It depends, but there are a lot of people that live with it for a long time. And a lot of people live very well with dementia. And so, but it's their families that don't necessarily live so well with dementia. And this is the difficulty, because we talk about living well with dementia. and we don't necessarily think of the family that way, right? And so I talk about, one of the things, my father-in-law, when he developed dementia, he was a really not a very loving guy. He had a lot of trauma. He never said, we use words like I love you. He was never very demonstrative about feelings, pretty inhibited, kind of did the right thing, quiet. He developed dementia. He became the best person you could ever imagine. He was on the right medication, but also he was more disinhibited and started talking about love and started dancing and singing and telling his grandchildren what a blessing they were. And he lived so well with dementia. And he taught me about this idea that, you could live well with dementia. But if you saw my mother-in-law, she was really suffering because everybody was so happy that he was doing so well. And for her now, she had a totally different man. It was great, but it wasn't easy for her because now she for sure couldn't share her grief because he was a better man and he was so happy. And how could you be upset that he's so happy, right? So I think it's just being aware that it's loss of not just the person, not just the relationship, but sometimes a lot of people have to downsize when their partner has dementia. There's the loss of your home. And the reason they have to downsize is because they can't afford to pay for care or to pay for a facility and the home they were living in. So think of all the losses that some of these families have to experience, right? So it's really multifactorial, this loss. So I think of it not just as the loss of the person, but the other losses.
That's actually a really good segue. Thank you, Adriana, because that comes up in the case that we're gonna talk about. Kathy, I saw you unmuted. Do you want to add something?
I was just going to point out that one of the things I'm seeing recently is that the partners are actually having to divorce each other because they cannot afford to pay for the client's hospital or nursing home stay and that. And so they've been actually filing for divorce so that otherwise they lose everything because they have minimal income coming in.
So horrible. Kathy, where do you live?
I live in Manitoba.
Okay, so in Ontario, we have something called involuntary separation, which basically it's a form that people complete at the point that they enter long-term care, because then they're entitled to more money from the government. And it's called involuntary separation because it's involuntary, but it allows people to increase their old age pension and finances to cover some of the costs. But that may be a provincial thing.
I've not heard of that. Maybe someone else. I know there's others from us here.
This is Marnie from Manitoba, and we do have that in Manitoba.
You do?
Yes, we do.
It's coming up in the chat that involuntary separation is a federal form. Manitoba has it. It's for people who are receiving the GIS, which I think is the Guaranteed Income Supplement.
Yeah. Oh, I'll have to let my client know that because he was the one I was talking to the other day he was filing for it because he couldn't afford to pay for her to be there.
Yeah.
Okay.
A lot of the times that form is filled out. The long-term care facilities help the families at the point of admission. Yeah.
I'm new to this area, so this is all new to me.
I work for long-term care in Manitoba, so that form is here. And it also just helps them separate their income so that the charges for personal care home is not based on both people's income. It's just based on the person entering care. My own grandparents had to complete that as well. So I always make sure to stress that point to people when I'm talking about it, because, nobody wants that to be the reason why they separate from somebody. So it really is only for the financial implications for a personal care home.
Yeah. But what's really unfair about the system is for younger people with dementia, that are not getting old age pension because they're not over 65. The problem is they look at total family income. And if you still have kids or kids in university, the money, I mean, is not the same, right? Like you need more money. And a lot of younger people, their mortgages may not be paid. And so they fall through the cracks, those folks. So when you have caregivers that are younger, the involuntary separation form is not so helpful. It's just for the over 65 group.
That's great. And it's okay, Kathy, that you're new to this. This is why you're in Echo. Yeah, I think Kay Friesen is saying they work in the MS clinic and people are under 65. So maybe it's a little bit of a different situation there, like Adriana just addressed. I'm gonna switch us over to the case.